responsible generation through his vocation. He is a regulatory affairs associate with Novartis, and he's based in Kenya. He doubles up as a co-founder of Culture Health and Social Innovation, and a social enterprise which is committed to improving access to quality healthcare services and promoting human capital development in Africa. And he's also the curator of African Pharmaceutical Network, that is APN, which is an initiative working to mobilize pharmaceutical industry players in Africa for knowledge sharing, policy sharing, and innovation, and nurturing discussions in efforts to improve access to quality, safe, and efficacious healthcare products and services for the African populace. During his free time, David loves to read, blog, and entertain friends. Over to you, David. Welcome.
Thank you so much, Mercy, and thank you everyone for this opportunity. To the Afro PhD team, it's a pleasure to be part of the discussion and to engage as we share insights on what we believe, or probably what we know has to be the role of the pharmacist, and to look at what mechanisms are there for us to bring pharmacists to the fore. And beyond bringing pharmacists to the fore, is the key is how do we deliver on our aspiration of ensuring that we realize the SDG number 3, that is good health and well-being for all. And on that account, the key bit would be taking and in using every single resource that is available within our spaces and making the best use of them. So on this account, my presentation today will be around modeling the integration of pharmacists in primary healthcare towards the realization of SDG 3. And as I go through the presentation, I know my colleague, actually, Manuel, has presented a case for immunization that is a very critical bit when we look at this. But as we go beyond the immunization component, what we need to ask ourselves from my perspective, based on the work that I do, and my passion and interest in pharmacy, the key is everything is about social behavior change communication and making it be a part of our programs and part of the system that we're looking at advancing progress in our communities. When you talk about family medicine, we are looking at people before they even become ill. That is at the healthy phase. Can we keep them healthy as much as possible? What are the infection prevention mechanisms that we're adopting? Disease prevention. What are the health promotion activities that we are promoting within the individuals? And in case they fall ill, what are the curative measures that we are championing for and that we are making accessible to the communities and individuals to make them be able to attain the positive health outcome that we wish for each and every individual. And ultimately, we'll move into the palliative and the curative, the palliative and the rehabilitative aspect, depending on which space in the continuum of healthcare services and the healthcare spectrum is this person as an individual and as a patient that needs healthcare services and healthcare provisions. So in this case, when I look at it from the dimension of what does primary healthcare entail? So it's the whole of society approach. Everybody has a role to play. And the key is to ensure that we all attain the highest possible level of health and well-being through equitable distribution by focusing on people's needs as early as possible. And that is what covers the continuum of care services that we're talking about. And in this case, we look at it from healthcare services that they need, the intervention. Let's say, for example, the physicians in the room, you'd be dealing with surgeries, operative procedures for an individual. Other than that, we are looking at the use of medicines, who ensure the medicines are available, the pharmaceutical supply chain optimization and related. Then we look at the additional procedure, for example, an injection, who is injecting the patients. Most of the times we have nurses coordinating such functions. Then ultimately, how do we ensure that the best outcomes are being achieved? That is where we now look at the additional role for the pharmacist. Now that's where the pharmaceutical care comes in. Medicines reconciliation, medication therapy monitoring. How do we integrate into such system and ensure that at the end of the day, the patient realizes the positive outcome that we all wish for? And those are the key things that we need to look at from that dimension. Then when we look at it in terms of the presentation that I had from Emmanuel, one thing that I want to make clear for all of us to understand is that pharmacists will practice across different settings. There's the one that is in the community pharmacy setting. And I know most of the times when we talk about pharmacists in primary healthcare, that is where we think of pharmacists. The person running a pharmacy store, a drugstore next to your neighborhood. Yes, there are some who are pharmacists, some are pharmaceutical technicians, technologists and related, but with a pharmacy background. That is the first phase. Another phase where we have pharmacists, we have different programs that are being run by different organizations across the world. NGOs are related. These interventions that are delivering from primary healthcare services to the communities. What are the roles of the pharmacists in such kind of setups? What are some interventions that they can deliver? Then we go to the public health system from hospitals at primary care levels and related. Most of the time, for example, using the case of Kenya, pharmacists would be found at level 3 hospitals, that is the primary health centers. then we move upward, and most of it's managerial position. So what are their roles in such spaces that ensure that primary healthcare, our aspirations in ensuring everybody has access to the primary healthcare services they need are being realized? That would be looking at, are they optimizing the supply chain to ensure medicines are not available? Because some of the times we're working in these institutions, but the most actually dispensed product in these pharmacies is out of stock. So you just indicate out of stock. Yes, you're serving 1,000 patients or 100 patients going through the pharmacy, but the most critical word that you tell them is out of stock. So what is the pharmacist at the higher level doing to ensure that the supplies are available? So those are some of the things that we need to look at. And as we look at that, we look at the other bit in terms of pharmacovigilance, pharmacoepidemiology. At the end of the day, if I'm using a medicine or a healthcare product, it needs to be safe for my use. And at the same time, in case there's any adverse event that is being realized, I should be able to get somebody to intervene on my behalf. What are pharmacists doing in terms of pharmacovigilance? And so I remember Emmanuel's presentation of vaccines. We have adverse events that are being noted. Who is reporting them? And who is dedicated to follow up on that in the different areas where we work? So, and then we look at it from a higher level, at the policy level. County pharmacies, let's say we have the ministers of health and related. If we have a technical advisor, or even the CS or the minister at all, who is a pharmacist, the key bit is that is a policy level. And our role cuts from the delivery of healthcare interventions, from health education, promotion, up to the point where we are forming policies and advising intervention makers, from development partners to business stakeholders, to deliver these solutions. And if we look at this from that dimension, then we are looking at delivering the intervention that we are hoping for. And those are the scope of the things that I'm mentioning here: health education and awareness creation, access to health products and technologies, pharmaceutical care, that is medication therapy monitoring, medicines reconciliation, adherence counseling and health programs management. Then we have pharmacovigilance, and referral is a critical bit. When you look at the patient journey naturally, oftentimes in our resource constrained settings, when I'm unwell, probably I'm feeling some headache or kind of, I'll go to a pharmacy, buy painkillers or even just management of the symptoms. Symptoms persist, I go back to the pharmacy again. By the way, the medicines you gave me last time did not help me get relief. And therefore, is there an alternative? Then at that point, probably you're giving the pharmacist or the pharmacy technician more information. They'll sell you some other medicine or medical product, which you'll go use. If you get relief, well and good. If you don't, that is where now you consider going to a hospital to seek healthcare services. Reason, the convenience of pharmacies being near to you when you talk about community pharmacies where they are. Then when you go to the hospital, at the end of the day, the prescriptions, the investigations are done, diagnostic procedures and related, a diagnosis is made. After the diagnosis, a prescription is generated. With that prescription, you have to go back to the pharmacy. So that is the whole continuum of what we are looking at. Where do we have pharmacies playing a role? And in every area that they play a role, they can deliver these interventions, from health education, awareness creation, providing medical services, the pharmaceutical care component that we're looking at, and ensuring that we are able to deliver on these. And being mentioned that in this session, I'm about the modeling of the integration of pharmacy in primary healthcare, then the question we need to be asking ourselves is, how do we make pharmacies be part of the primary healthcare teams and to be able to deliver on our primary healthcare aspirations as a community? So when we look at these, they have to be integrated position within the healthcare chain to deliver this. And some of the things that I know, over time, we've all had discussions, let's say, for example, within the pharmacy space, and even other policy discussion forums on the role of a pharmacist, what a pharmacist can deliver. And there are even publications and reports that are actually contributing to this. But the only problem that we also acknowledge that we have is, we talk about what we can do, but at the end of the day, where we do it, we don't document it. And some of the times we talk about it without actually doing what we need to be doing in these areas. Probably it could be because of the interprofessional strife and related challenges, lack of the skills that are required for us to be able to deliver on these services. And based on this behavioral change matrix that I mentioned, lack of awareness that we can actually deliver such interventions. So then how do we ensure that it's happening? When you go to a government institution, there's always a service charter on what they are able to do and what they are offering in that institutions. And it's not only in the government institutions, even within the organization we run. We have an organizational profile that outlines what kind of interventions we're doing. When we talk about Afro-PHC, what do you do? Who are the members? Who are the stakeholders? And what services are you offering to your clientele? And in this case, when we're talking about such kind of a model is, as a pharmacist, depending on the environment where I'm practicing, what interventions am I delivering to the people? What services am I offering? Then the key is to ensure that we establish a service charter. And in the next slide, I'll be talking about how do we come up with a service charter so that at the end of the day, when we talk about pharmacists delivering services in primary healthcare level, then we know what does it entail. If we're talking about vaccination, what vaccination programs are they delivering? And why is it that some of them are not doing it at the same time? Because the other things that we forget about is they are drivers for people to practice, and they are the disincentives to practice. If a government institution is offering the immunization services, it would be good, yes, that is the normal standard procedure within the public health institutions. But where they're not able to reach the communities, we have primary care pharmacies, that the community pharmacies that are available and accessible to the communities. How do we integrate community pharmacies to be partners to the government institutions and the government framework so that they're able to deliver? Who is going to offer remuneration for this? Who is tracking these kind of deliveries? And I remember in 2018, when I was doing my attachment, article level 5 in Kenya, one of the key things that I kept asking myself at the maternal and child clinics, they're offering vaccination services, yes, which is good, but in these vaccination programs that you deliver, what happens when a patient doesn't come back? When a mother doesn't bring their child back, how do you know whether they've been vaccinated at some other location? What is our tracking mechanism to ensure that we follow through? And in case that doesn't happen, how do we integrate other people in the local community that can deliver? And such a thing that we need to be thinking about. We might not be able to deliver, but we can structure how such interventions can be done. So once we have a service charter that outlines, based on the disease patterns, for example, if you are in a diabetes endemic zone, non-communicable disease, or an infectious disease zone, let's say, for example, in the Kenya, we have the Lake region predisposed to malaria, then it means as a pharmacy service provider, you should be able to have a malaria management program that is able to, one, diagnose, and other than diagnosis, you are able to offer the therapy, that is the drugs that are used for management. In case some of the children, for example, when we talk about the mortality rate for children with malaria is high for children less than 5 years, it means in such cases, there are high likelihood that there will be complications. Do you have a referral system for such kind of a case? In the service charter, you know, where do I refer? You have even an established engagement with other higher level healthcare institutions so that you can refer them to those institutions when they need specialized care. When you're dealing with neglected tropical disease, for example, leishmaniasis and related, do you have vector control, environmental protection measures? Are you part of the community delivering such solutions? That would come into that. Then once you've established a service charter, knowing what are the things that I need to high priority areas that I need to intervene in, you have that in place. Now you move to the next phase. If I'm going to offer psychosocial support for patients with mental health services, with a high, considering I'm in a locality where there's a higher burden of mental health disorders and distress, then I need to have the skills and the capabilities to be able to deliver on these. On that account, then capacity building and upskilling of pharmacists to deliver on the services as outlined in the service charter comes into place. Because you're not just building, actually training them to get skills. And that is one thing that I acknowledge based on a comment that I saw in the chat. We need retraining or a review of the curriculum. A review of the curriculum would be good if we know what interventions or what the conditions these pharmacies are delivering. And that is now where the service charter is informing our training and capacity building programs. Then we look at the community engagement. If primary healthcare is a whole of society approach, and if it's a whole of a society approach, then we have to all engage with the people within the communities where we're operating to ensure we are supporting them. There's no way I'm going to talk about the risk of tobacco smoking as a contributor to cancer. And next to my shop, I have my actually next door shop is selling tobacco, and nobody's ever engaging them on the impacts of such kind of sales. And maybe somebody in the community is actually planting tobacco as a plant, cash crop for them. So how am I engaging the community to be able to deliver on the services? When you look at it from the healthcare component of delivering healthcare services, we can talk about health promotion. Normally, for example, in my community, I have a couple of friends that we normally go for runs and related. If you're part of the community, you look at it as health promotion. Can we go have, like, let's say, weekly physical activity exercise that will keep us fit? You become a part of the community and deliver interventions that's supporting them to be able to achieve their healthcare needs. Then ultimately, as we do all these, evidence generation and advancement of science. There's no way we are going to talk about what the contribution of a pharmacist is, or not only pharmacists, even any other healthcare practitioner, in advancing access to quality healthcare services without evidence of what we are doing. In 2020, we had the World Pharmacist Day, 25th September 2020. And the theme for that day was Pharmacists Transforming Global Health. A good topic, yes. And it was coming at a point when we are all suffering from the catastrophic impacts and the effects of COVID-19. Yes, so we need to address global health, and we have a role to play as pharmacists. But the question that I was asking myself, most of the global health challenges are endemic and actually domiciled within the African continent. And as that is the case, what is the evidence of what pharmacists are doing in Africa? If you went online to any resource, could you point out this is the contribution, this is how pharmacists are transforming global health in Africa? We are not generating that evidence. And therefore, however much we can engage in policy leadership, advocacy, and every other political forum where we are looking at getting the buy-in of other stakeholders, it might not work because we don't have a case that is localized and contextualized to our own working model and environment. And that is one thing that we need. Then finally, the second last thing is the financing aspect. Every intervention that is offered, there is a financing component. It is a resource. So what resources are we looking at? The pharmacist who is delivering these services, who is offering the primary healthcare service that we're talking about, how are they being remunerated for the services they offer? Who is paying for such services? That is one thing. Two, the healthcare products. Let's say, for example, when they're offering vaccination, the government would be supplying them here. Somebody is managing the supply. But who is managing the logistics in terms of storage in, let's say it needs cold chain measures, electricity bill, who is financing that aspect? And those are some of the things that we need to look at. And one of the key bits of what I think is an advancement that we can look at as pharmacists and every other person in looking at positioning pharmacists in primary healthcare. If we see access to healthcare being a challenge because we don't have government facilities closer to people, then imagine if we could position community pharmacies, which are almost in every neighborhood, as primary care facilities. In the Kenyan context with the NHIF capitation, so that I could choose a pharmacy next to my door, next to my house, as my primary care facility. It means that person on a monthly basis, based on the Kenyan rates, will be receiving 200 Kenya shillings. With that 200 Kenya shillings, when I'm having, let's say, for example, headache, I can go to that pharmacy and get paracetamol using my NHIF cover. I have an incentive to be insured by the National Hospital Insurance Fund. But if every time that I have a discomfort, I go to the pharmacy, I have to spend my money, then why do I have to get an insurance by the national government? There's no imperative because maybe I'll never use it. And oftentimes, let's say, for example, for the last 2 years, I've not used my insurance cover. I do pay, yes, but if I had the option of actually getting services from it, even those who are not paying would have a reason to go for that. Then the last bit is in the policy leadership, advocacy, and strategic partnership. We need to get allies and partners who can work with us on that journey. And as we do that, we need high-level leadership commitment to advancing these. And that is where now we look at it from what is the national imperative, the national interest. In the Kenyan context, I could talk about Big Four agenda. In the African landscape, in the pharmaceutical industry, I can talk about, one, we have regulatory harmonization, which is driven by the African Medicines Agency, partners, International Association of Patient Organization, and related. Then we leave that aspect, we can go to the next one, when we're looking about pharmaceutical supply chain. Over COVID period, there was establishment of the African Medicines Supplies Platform, AMSP. That is another agenda. Then we look at the African Medicine Production Plan, Pharmaceutical Manufacturing Plan for Africa. And that is on the backdrop of Africa Continental Free Trade Area. So there's high-level political interest about different agendas. How do we link these to our own interests within the pharmacy landscape and the healthcare landscape at all, and see that we are selling an agenda that is buying into actually helping the political leaders and governance experts to address some of their priorities in terms of investment. So if we do that, we are able to drive that agenda, and we'll be able to have them as allies even at a national level to support our integration into primary healthcare interventions, because they know if a pharmacist is working as a primary care facility, most of the communities or even my electorate will be able to access the healthcare services they need. That is a win for them. So how do we position ourselves, and how do we plug into strategic initiatives that are being driven by such kind of high-level leaders and governance frameworks? And on this particular slide, the main thing was to look at what would be the mechanism of establishing a service charter. The pharmacy service charter would start from the needs assessment. Where am I locating my pharmacy? If I'm locating a pharmacy in my rural community, then I need to understand what are the diseases that are affecting most of these people. When you engage community health workers, the local health facilities and related, you already can map and see what is the data that is available. And you can even look at the national health utilization index metrics. What health services are being utilized by majority of people? Where do they seek them? And how do I address some of the needs in my own community where they might not be able to see them? Then once you do that needs assessment, you come up with a service basket. And that service basket looking at the priority conditions and priority healthcare needs of the community from which you come. Therefore, you now have a portfolio of the services. So out of that, you now have the core services. Pharmacies, normally, the standard operation that everybody knows about a pharmacy, when you hear about pharmacies, medicines. That is a core service, core product that we can deliver as a services. The medicine reconciliation, medication counseling and related, those are key. Then we look at now specialized services. And when you talk about specialized services, we are looking at emerging disease areas. Those are some of the things that I'm going to mention in this next slide. So let mental health space, sexual reproductive health, contraceptive, fertility products. Other than the fertility products, do we have specialized skill to offer additional services in that case? Do we have a partnership with the lab so that we can be able to monitor the drug levels of a particular patient upon treatment, or even the different indicators that we are looking at? Then we are able to make an informed decision. So once we integrate the core services and the specialized services into the service basket, we have a service charter. And then those are services in addition to medicines and health products, which is our forte as pharmacists in terms of service delivery. And some of the key things that I want to just highlight as I finalize, wrap up this session. Some of the emerging areas that I feel as pharmacists we can deliver value as players in primary healthcare would be one, mental health. When you talk about mental health, just from the depression, stressful conditions, anxiety-related conditions, most of the times because these mental health disorders and distress would present as physical conditions. So probably I'm feeling headache, I'm having GIT discomfort and related. When I go to a pharmacy and try to express my case and actually get some insights from them, if it's a mental health condition, mental illness, or mental disorder, they would be able to do first aid, offer first aid, that is the psychosocial support. If they feel there's need for additional extra support, referral services come into place. And then in case somebody is prescribed for medications, then they'll be able to support them in delivery of the medicines and also advising in medicine use and continued follow-up, because in terms of our delivery model, we talked about community engagement. They are part of that community. In sexual reproductive health and related, contraceptive use, everybody is buying them from pharmacies and related. Yes, they're good to be obtained from the pharmacies, but what additional services can pharmacies deliver? Contraceptive services, that's good. Fertility care products, they're available. Do we offer fertility clinics that are pegged on our delivery of services? Somebody would come and buy, for example, Fertilion or something, a product that is a fertility care product, but who is guiding them on what is the use? Who is helping monitor the actually optimal outcomes out of the use of that product in the community level? Probably they're not there. Then the other bit is in menstrual hygiene and related when we talk about SRHR. Menstrual hygiene is a critical component, and we're saying no lady should be denied the dignity of having access to sanitary towels and sanitary products. But at the same time, this is a reflection that I had over the COVID-19 period. Government of Kenya had a distribution plan for sanitary towels through schools. Over COVID period, schools were closed, and therefore, some of the ladies that were reliant on this kind of services delivered by the government through schools were not able to access them. But in every neighborhood, we have a pharmacy. What if there was a structured public-private partnership where the community pharmacies serve as logistics partners to the government in delivering these sanitary materials? Then it means there would be continued and reliable access to these services and products. But that is not something that is being practiced. So how do we look into such domains? Non-communicable diseases, the diagnostic measures, management, referral and collaborative practice with other stakeholders. So those are emerging areas. Neglected tropical diseases, we can talk about vector control, health communication. I mentioned that earlier already. Then infection prevention and control, infectious diseases, that is IPC, curative care referral services. That is the same looking at the continuum of care and the care services that we need to deliver. Emerging areas, everybody is talking about the beauty industry, yes, and we have skin care, skin conditions. Everybody is looking at using probably a skincare product, or almost all of us used our lotion or a body, I'd say jelly, a petroleum jelly at one point in time. So why did you choose that particular product? And some of us were suffering from skin condition, let's say, for example, acne. Who is offering you those care services? And being within the landscape of services that can be delivered by pharmacies, what if we have a cosmetologist pharmacist who is able to support patients with skincare conditions, including the fungal infections that might be there? That would be a win. immunization program, that one I'm not even going to talk about because I know Emmanuel did a wonderful job at that. Emergency response and preparedness, we had just the most critical one. COVID-19 happened, yes. What is our response interventions? Currently, we are having the challenges in Russia, Ukraine. There's unrest. With this unrest, the people who are being affected are the local communities. What healthcare services can we support as pharmacists in delivering interventions to the communities? Pharmaceutical supply chain, no need to go into that because that is an area that we all know. There's a need to ensure that we have reliable access to medicines, and those reliable access to medicines, we should be of quality, safety, and efficacy standards that are recommended by the global standards and regulatory measures. On patient safety, every care that is intervention that is delivered to patients, we need to ensure that it's meeting the standards. That is where patient safety comes in. Pharmacovigilance, as I mentioned. And I'm looking at pharmacovigilance not only in the healthcare system, but even from an NGO perspective. I remember last week I had a conversation with a friend, and this is what was coming up. What can a pharmacist offer in an NGO setting or a nonprofit organization that normally does medical outreach programs? The first thing is you need to do assessment of the products to ensure that they're registered in the country where they're being used. Because if they're not registered, then in case of any adverse event, who is going to take responsibility? Who is going to take charge of that? Can you educate patients on how to report any adverse events that are available? Then in case they happen, how do you monitor such investigation measures? How do you correct, what are the corrective actions, preventive actions? And who is capable to actually follow through the metrics, if not a pharmacovigilance expert? So those are the aspects that we look at in terms of patient safety, because at the end of the day, the care that we offer patients should not harm them, but should be able to empower them to achieve the best outcome they're hoping for. And self-care. As individuals, we are all keen on having control and self-determination over our lives. And that aspect on autonomy is what we are aspiring for. But the key bit is, how do we then get such kind of control over our own healthcare services without having to be going to be hospitalized or anything? It can be done by having people, educators, and pharmacists can offer that education. Pharmacists can offer access and delivery mechanism. For example, now we have some pharmacies that are offering delivery services for medicine that are bought through their platforms. That is an aspect of self-care. So in self-care is about educating patients to be aware of the general public health literacy. Then from the health literacy, ensuring the products that they need are available, and employing the use of digital platforms and digital technologies to ensure that patients can make the best use of the information and the health products and services that you've made accessible to them. Ultimately, as I conclude, for us to be able to achieve all this that we're wishing for, we have to think in a systems way, systems thinking. And then we have to be focused on what intervention are we hoping for. We don't need to be unilaterally and actually confined to a particular area of work, but we need to be broad-minded and thought thinking of what interventions would we need to help every patient or each patient to act as human beings. Rather than treating a disease, you're treating a person. And that is where we talk about the human-centered design. What makes the patient have the best outcomes at a personal level? What meets their needs? Once we're able to deliver on that, by applying a system thinking, knowing that we're not able to deliver everything at our own level, but we need to integrate and work with others, we are able to deliver on our aspiration. And at the end of the day, we would be in a better position to achieve the SDG 3 as we all wish for. Thank you so much.
Thank you so much, David, for that wonderful presentation. In fact, you've covered so much scope that I'm sure a lot of people did not imagine a pharmacist would be able to function in that area or be able to contribute in so many different areas of healthcare. So we're going to take a pause here. And if there's anyone with any burning questions, please raise your hand and we will take, for the next 5 minutes, we'll take a couple of questions. On the chat, I can see Senkira is asking, how should we ensure self-efficacy among pharmacists? I don't know if Senkira would like to expound a bit more on that. I'm checking to see if there are any raised hands right now. If you have any question on David's presentation or Ekanem's presentation, you can go ahead and raise your hand. I can see 2 hands. Let me see who these are. Sorry, I'm not able to see everyone on my screen. Just a minute. I thought I saw a hand raised.
Is Teresa ready?
Teresa, please unmute. Go ahead. Teresa, are you able to unmute?
You can all unmute yourself now.
Yes, thank you. Now I can unmute myself. Thank you very much.
Go ahead.
Great presentation there. My question is, among the plans, like Dr. has shared lastly about the service charter, the community service charter, which is very, very good. I would want to ask him what plans would be in place to maximize on a multidisciplinary team approach for primary health care. How would pharmacists then work with other players, health care providers at the primary level? Because there's so much space, there's so much into that space where pharmacists have touched on that they can bring in value. But how then do they integrate that in a multidisciplinary team? Thank you.
Should I respond to that, or we
yes,
take others
please
first?
go ahead. Yeah.
Okay, thank you. So thank you, Teresa, for the wonderful question. And I think it's possible for us to work with others. And that is the overall scope of what I'm envisioning with a service charter in place for community pharmacy. When we have a service charter, we know what is the scope of what we can deliver. But we also know clearly what is beyond our scope. And therefore, for example, if I talk about something that I'm passionate about on mental health, I would do first aid for a patient because based on my psychosocial training, basic first aid, right? After that psychosocial support, I would be able to acknowledge that this patient needs additional care. Therefore, I'm able to refer them to a psychotherapist or a neurologist somewhere who would be able to offer specialized care. And therefore, it means in our service charter, even in an organizational level, in terms of structuring your services and interventions, you already know I need to have partners who will be able to help me in these particular areas. If I'm offering mental health services in my pharmacy, then I need to know in mental health services, there's a scope of what I can do. There's a scope of what is beyond my reach. And therefore, for that, I already have structured partnerships with people who can deliver the additional services. That could include a neurologist, a psychiatrist somewhere. Then for the supply, for the medicines, I'll be able to deliver that because at the pharmacy level, I may be having them. For other conditions, let's say, for example, you need to manage somebody with malaria, diagnostics. Are you allowed to offer by law to offer the initial diagnostics? I know the rapid diagnostic kit is allowed, but if anybody needs the, let's say, PCR test and related, you need to have now partnership with lab people to be able to do the diagnostics for you. But after the diagnostics, a clinician or a physician can help make prescribe the medication based on that diagnosis if you're not allowed to prescribe in the jurisdiction where you work. But at the end of the day, you are still within the matrix knowing this is what is within scope for me. These are the services within for the same condition, for the same healthcare need that is beyond me. And therefore, for that, I need others who are able to meet that, to bridge that gap. And that is where, let's say, for example, when I talk about immunization, other pharmacies in a community pharmacy, I could be offering logistics and storage services where they need cold chain. But the community health workers can be taking medicines from me at the pharmacy to vaccinate children in their communities. At the end of the day, they'll come and report back and actually return any remaining doses for future use. That is already integration and collaboration with others. So we need to look at what are we offering and what do we need more to be able to meet the needs of our communities. I hope I've answered you better.
Thank you so much, David. Actually, you've actually answered another question which I've seen in the chat, which was asking how do we ensure cadres and professionals stay within their scope of trained competence, which you have answered quite well in the end with the whole, look at the team you're working with, do what you're doing, and what you cannot do, someone else is able to do, and they should be able to support you in that. I'm going to take Funmilola, then there's someone, I don't know, health and music. You can go after. I think you can rename yourself so that we can know who you are. Funmilola, please go ahead.
Good afternoon. Thank you, David, for your presentation. But I just want to, I mark some things that is happening in Nigeria in particular. Most of the PHC, they don't even have drug and they don't have human resource. Most of the PHC, they don't even have pharmacy. So I don't really know if there's no drug in PHC, how will the pharmacy function better in the PHC? Am I clear?
Could you please clarify what a PSC is?
She said PHC, primary healthcare.
Oh, okay.
Yeah.
So functioning better without medicine, that is not a possibility. And that is why when I was starting the presentation, one of the key things that I tried elaborating is the fact that our services are not only limited to medicines, but in whichever area we are, we need to acknowledge there's an intervention that we need to offer. When I was talking about the sub-county pharmacies or a county pharmacist, they are key in terms of ensuring the management of pharmaceutical supply chains are optimal. So there's no optimal management pharmaceutical supply chains when the most used medicine is out of stock. You're not serving any need. And that is where we have a challenge. And I think that comes to the aspect of what kind of needs do we have in our communities? Medicines have to be there. So there's no way that you're going to deliver on primary healthcare without medicines. And as you're doing that, then the other bit would be, what are the other innovative mechanisms that you can adopt? Because one of the things we have to acknowledge is we might not be able to change the system and actually get medicines available instantly from the government when we're dealing with primary healthcare centers. But what options are there for you? And I'm going to give a case of some intervention that we designed at Kasarani Health Center in Nairobi, Kenya last year, but one around August, October. I was working at the primary healthcare facility doing my internship, and we noted that we have patients who are diabetic patients, hypertensive patients, who used to come to the facility, but oftentimes we were selling out of stock. So once they've been diagnosed, and actually some of them come with their prescriptions and there are no medicines, we tell them, go buy to the pharmacy next to where you come from. Some of them will tell you, by the way, I'm not going to buy it because I don't have the money now. Or maybe they'll buy half the dose unrelated. So what we ask ourselves is, what other options are there? Based on the work that I was doing with ReCulture in terms of health communication and advocacy, and then the institution and some of the people that I'd met, we had a partnership with PharmAccess Foundation, and we had the partnership with the Kasarani Health Center, that where I was now interning. So being patients will always come to the primary health center to get their care need, to meet their care needs. As an individual, based on the program that I'm doing with ReCulture, I would now reach out to MEDS, Mission for Essential Drug Supplies, and we establish a patient support group. So on a monthly basis, the patients are contributing $5, 500 Kenya shillings. That 500 will ensure their medicines are refilled. So on a monthly basis, they are assured of getting their medication. But this is now a parallel program because they are paying for the medicines and we are sourcing it through the patient support group that is available to them. As we're doing that, we are designing a new model of practice that will ensure they have access to medicines, but also holding the government accountable. Where we have challenges, because there are budgetary allocations for delivery of medicines in these primary health facilities, can you offer additional payments in case we have a shortage? So such kind of interventions need to come in, but we need to look at it from what can we do now and what is the hope? Because maybe the patient support group, it is self-reliant, they are going to take care of their needs, but how is it sustainable beyond ReCulture engaging and supporting it? It is a function of the government. How does the government plug in and support it? So such kind of approaches can help us better. I hope I've answered you.
Thank you so much, David. And in the interest of time, we'll take more questions after the next presenter because she has another meeting. So I'll remember to take your questions and also read your comments after her. So our next speaker is Ms. Tolulope Osegebsan. She has over 10 years of work experience across the public health sector.